All right, manual therapy assessment. So, is it hyper, hypo, or normal mobility? So, the quantity of motion. The infill, is it boggy? Is it a distinct stop? So, we might feel less of a distinct stop, say if we had guarding restricting motion, or if there was some fusion there, or we might not be able to get that stop if it's painful for the patient, right? So our provocation as well, something we want to note. So is it hypo, hypermobile? Does it provoke the patient's symptoms? Very helpful information there. And generally speaking, with translatoric joint assessment, we could see traction, compression, or gliding. So typically with this lumbar spine, we're going to be talking about gliding. With traction and compression, we could also see more so with the hip, the knee, the foot and ankle. And PAVMs, passive accessory intervertebral motion, those are going to be tests like CPA, so central posterior to anterior, or UPAs, unilateral posterior to anterior. Those are accessory motions. Those are motions that we can't reproduce naturally, but we can't reproduce naturally on our own, that is, versus our passive physiologic intervertebral mobility testing. So those would be in motions, which would be natural. So say our flexion, extension, rotation, which we'll have coming up here shortly. Now, tests or studies that have examined how well we can identify hyper and hypomobility with different tests essentially have found that we're not that great at noting hyper or hypomobility. So this one study, quite interesting, looked at clinicians who measured passive intervertebral motion, either passive physiologic and accessory motions, and then looked at x-rays for the amount of segmental motion that was actually occurring. So a comparison was made there. And as you can see, our positive likelihood ratio is not really that great when it comes to our PAVMs, so our PAs, our UPAs. That being said, a little bit better when we get down here to correctly identifying our hypo or hypermobility when it comes to PIVMs, so passive physiologic motion. So the utility of our PAVMs might lie more so in our ability to determine if there's a problem at a segment, if it provokes the patient's symptoms when we do it. So these results would be suggestive of PIVMs being better for identifying hypermobility and PAVMs for identifying pain and confirming a segment as being problematic. So our CPAs, our UPAs, you can read through those instructions there. I'm going to go ahead and flash up a video. Any second now.
So for posterior, anterior joint mobility testing, we're going to palpate, finding our lumbar spinous processes. And once we find our L5, or we could start at L1, either way, we're going to put the area of our hypothenaric eminence right over the spinous process. We can take our other hand and cup around to show you that hand position. And we're going to get our body directly over that spinous process. We're going to use our body weight. Now we're going to do around 3 gentle nudges and then 3 tougher nudges if the patient's able to tolerate that without reproducing any of their symptoms. This is something where we're looking for the provocation of the patient.
So does it have to be exactly 3? No. Might I do 1 or 2 or maybe even 5? Yeah, so that being said, 3 is commonly described, but somewhere around 3 is acceptable as long as you can feel for what you're trying to find.
Also, if we reproduce radicular symptoms that the patient complained of, that would be very important as well and could really help implicate a segment with lumbar radicular pain or radiculopathy. And we're going to test one segment and then move to the next segment. and work our way through the lumbar spine. Now, I prefer the one hand testing as well. So we're going to get our hand on the patient's back here, push on the patient's back. Let's push on those spinous processes, that is, with the hand. Now, UPAs, we're going to come over the area of the facet joint towards the area of the transverse process, thumb over thumb here, and we're going to try to push on the patients in that area. And we're going to work our way down or up the spine, depending on where we started, on both sides. And UPA being unilateral, posterior, anterior.
All right. So, as we saw with that, again, feel free to read through our instructions here. This is more for reference. Now, our passive physiologic mobility testing, I'm going to ask you to pause your video and go watch those videos that I'll post on the Canvas site. That being said, they're kind of long videos, and I think that breaking them up or just going ahead and accessing those separately is really the most efficient way to go through this.